We're going to finish our concept of mobility out by talking about Parkinson's disease. You'll see some places that call it Parkinson's disease, some call it Parkinson's disease. Either way, it's the same disease. So just as a reminder, the concept of mobility is the musculoskeletal system working with the circulatory nervous system to allow for movement. So this disease primarily affects the nervous system. It's progressive, it is terminal, meaning that it is not something that can be cured. It's a progressive degeneration of the basal ganglia and loss of dopamine producing neurons. So as you lose dopamine, you increase cholinergic activity. So you have movements, but they are disorganized and involuntary sometimes. I almost like to think of this as like a short in a circuit, and the message is just not being carried through the way that it's supposed to be. So our risk factors are going to be age. The incidence increases as the person gets older. This is more common in males than in females. There are some environmental factors, like living in a rural area, for example, the incidences are higher there. And then there's a genetic factor too. So if you have a parent that has Parkinson's disease, then you're going to be at an increased risk of it. So we make our diagnosis mostly based on the symptoms that we see. There is a really nice chart in your Pearson book on page 955 that shows all of the symptoms. These are the most common ones that you'll see. You'll see involuntary tremor usually starts in the hands with something that we call pill rolling, which is where you're moving your thumb and your two fingers together. And it's increased whenever you try to go and do something. So if you go to reach for something, the tremors increase. They have a mask-like face, almost expressionless, stooped posture, really rigid muscles, and they have a slow shuffling gait. So you almost think of this as like a zombie walking around, it's like the old zombie movies, that this is kind of what the person's going to be looking like. There's also some cognitive changes too, like anxiety, panic attacks. They may have trouble sleeping, so they'll be fatigued, irritable. So just make sure you turn to that page in your book and look at all of the signs and symptoms that you may see. So we make our diagnosis based on that. We'll also maybe do a DAT scan, which shows us the amount of dopamine that's available in the brain. We'll do an MRI and CT just to rule out anything else, like MS or maybe a stroke, because an MRI and CT on a patient with Parkinson's disease is going to show up normal. So treatment for this, our go-to is going to be carbidopa-levodopa. Levodopa is a naturally occurring chemical that converts to dopamine in the brain. This is something that we usually wait until they're later on in the disease process because it has a wearing off effect. So we don't want to give it early and then it wears off, and then when their symptoms are very severe, we don't have anything to give them. So carbidopa is usually given with levodopa because it allows for the levodopa to be carried to the brain and convert to dopamine in the brain rather than in the bloodstream. It helps it to cross the blood-brain barrier. So I almost think of carbidopa as like a backpacker that stuffs levodopa in its backpack and then carries it up to the brain and unpacks it so that it can convert to dopamine. If somebody is on this medication, they're going to need a lot of education. This can interfere with a lot of the medications that they're already on. It can also cause some orthostatic hypotension. So think about fall risk. Somebody who has Parkinson's disease is already at a big fall risk because of that shuffling gait. But now they're going to be at an even bigger risk because of that orthostatic hypotension. So we need to do some education on that. Also, if this is going to affect their diet, if they eat a high protein diet, it's going to interfere with the absorption of this medication. So we may have to work closely with dietary. I'll talk about diet in a second. So dopamine agonists extend the availability of dopamine in the brain, so it kind of gives us more bang for our buck with whatever we have there. The dopamine modifiers, like MAO-B inhibitors and COMT inhibitors, they allow us to extend the period of time before we have to give carbidopa and levodopa. So you may see somebody start out on these two and then move to carbidopa, levodopa. Anticholinergics decrease the amount of acetylcholine, so they decrease the tremors that you see. But just think about the side effects of anticholinergics too. The person's going to be very dry, so we need to make sure that they're getting enough fluids every day. That may already be difficult for them because of some of the symptoms that they're having. Exercise is going to be important, keeping those muscles moving, making sure they're still flexible, so yoga and Tai Chi are really good for that. They may work closely with physical therapy, and occupational therapy is going to be really important. They may help with assistive devices for this patient. Things like, maybe like a shoehorn to help with putting clothes on, or devices to help with buttoning clothes, using Velcro rather than tying shoes. So things like that, things that will help with those fine motor movements. They may also help with, they may work with dietary to think about things like utensils that have a bigger handle that's easier to hold, or non-spill drinks, plates that have lips on them so they can scoop their food up more easily. So, because feeding themselves is going to become very difficult for somebody with Parkinson's disease, especially the further along they get in the process. So speech therapy is really helpful too, because speech therapy works with anything from the neck up. So think about swallowing and cognition, both. This person may become really fatigued when they're swallowing and eating, so we may have to space their meals out, and swallowing itself may become difficult, so they may be put on thickened liquids or even a pureed diet as the disease progresses. And diet's going to work real closely with them too, because they often aren't getting enough nutrition because they get so fatigued while they're eating that they just stop eating. But also think about, they're constantly rigid, and so they're burning a lot of calories all day. We also have to think about the fact that they probably can't eat a lot of protein because they may be on this carbidopa levodopa. So we need to make sure that they're getting what they need, and we have to work closely with dietary to do that. So we may have to do like a food diary, like to see how much they're eating every day. We need to make sure that they're getting enough fiber so they don't become constipated. We're probably going to have to work really closely with family too, because often this person's going to get to the point that they can't perform their activities of daily living anymore. So they may require a caregiver, and that can be very burdensome on the family. So this is a difficult disease for everyone that's involved with it. So make sure that you do your readings and come prepared to class to ask questions, and we'll go over these medications a little bit more in depth in class. I will see you there.